Good evening, everyone. My name is Swati. I'm a musculoskeletal radiologist here at BIDMC in Boston, and this is AJR's Behind the Scene, an in-depth look into the inspiration, investigation, and influence of latest AJR publications. I am so excited to have Dr. Sarah Kamel here as our guest today. She is an assistant professor of musculoskeletal radiology at Thomas Jefferson University, where she did all her training. And she is the first author of not one, but two recent AJR publications. Sarah, welcome, and thank you for being here with us.
Yeah, thank you so much for inviting me. It's my honor to be here today.
Great. So you have two papers. One is the paper on ultrasound-guided carpal tunnel release, which I am very interested in, since I'm interested in nerves and in ultrasound and in procedures. And the second paper is an AAWR society endorsed paper, but I want to begin with the carpal tunnel paper. So can you tell us a little bit more about your work and the procedure and just how you decided to write this paper and do research in this field?
Yeah, sure. So I'll start by telling you a little bit about the procedure itself. So basically, it's a minimally invasive way of transecting the transverse carpal ligament, which is the cause of median neuropathy in patients with symptoms of carpal tunnel syndrome. And the device that we use is shown here. It's called the SX1 microknife. And basically it features a retractable hook blade that's housed within that balloon seen at the tip. And we can inflate the balloon by pushing the lever at the end. And what that does is protect the blade from the surrounding structures in the carpal tunnel. And then when it's appropriately positioned, you can deploy the blade and retract it to transect the ligament, therefore relieving the patient's compressive neuropathy. So this is a depiction of where we place the device within the carpal tunnel. So there's a transverse safe zone, which is basically the space between the median nerve and the ulnar artery. And as long as the ulnar artery is not directly on top of the median nerve, then this procedure can be performed safely, and there's space for the device to be placed and the balloon to be inflated without injuring any of the structures. We also look at a longitudinal safe zone, which is the distance between the distal extent of the transverse carpal ligament and the superficial palmar arch, and again, to make sure we're not injuring any vessels during the procedure. And this is an ultrasound image of the device here in the center with the balloon inflated. And as you can see, it pushes the median nerve off to the side and protects the contents of the carpal tunnel. And then we're able to deploy the blade. As you can see here, the blade is being deployed. And then we're able to transect the transverse carpal ligament, and we usually watch this in short axis again to make sure that none of the structures are in the way of the blade. So basically what we've been seeing is that patients are having rapid recovery times, partly related to the fact that the incision is so small. So this is a patient who just 2 weeks after, you can see her incision here is about 4 to 5 millimeters. And at 1 year, the incision is completely gone. There's no scarring. And this is, in comparison to a 5 to 40 millimeter size incision in patients who undergo endoscopic or open surgery. And just to quickly summarize our results, basically we administered 2 different questionnaires to the patients who were in our study. The quick disabilities of the arm, shoulder, and hand, and the Boston Carpal Tunnel Syndrome questionnaire. And basically our results showed that patients demonstrated a statistically significant decline in their scores, which means improved functionality and reduced pain at 2-week follow-up, and even furthermore at long-term follow-up, which was performed over 1 year after the procedure. Also, the gross majority of patients were really satisfied with the procedure. And the people who were maybe not so satisfied, this procedure was kind of done as in patients who had mixed symptoms of carpal tunnel syndrome as well as an underlying neuropathy. So they were just sort of desperate for anything that could potentially help. But the overwhelming majority of patients were very satisfied. So that was pretty much a summary of the findings of our study. And since this paper's been published, we've performed over 170 of these at our institution. So again, with similar great results.
Wow, that is very impressive. That is a very high number of procedures. Can you tell me more about the process of setting this up? For instance, if people wanted to start offering this procedure, who are your referrers? What is the recruitment process like? what is generally your advice for people who are interested in offering this at their institution?
Yeah, absolutely. So the first step would be to contact the manufacturer, which is Sonex, and they will arrange all of the training. It'll start with some didactic sessions, and then they will come to your institution to go do some hands-on cadaver training, and then they will be involved for the first several procedures that are performed on patients. So it's a great resource, and they're very involved with making sure that their procedures perform safely and correctly. And then basically our experience in terms of referrals was to focus on primary care specialties like internal medicine, family medicine, rheumatology. We're not fighting the surgeons for their patients, but primary care specialists are, always looking for patients to have a low cost effective solution to their carpal tunnel problem. So that's where the bulk of our referrals come from. In terms of getting this up and running at the hospital, I will say one of the conditions of doing this at our hospital was they asked us to be willing to train any surgeons who wanted to learn the procedure. So that's always, kind of a negotiating power.
Okay. What is the training process like? Like how long do you think it would take for someone, and what qualifications would they have to have before beginning to train for this?
I would say that you have to be very comfortable with ultrasound in general, identifying the structure. So before we started doing this procedure, what we were doing was hydrodissection of the carpal tunnel of the median nerve, hydrodissecting it off the transverse carpal ligaments. So, if you already have a good baseline comfort with identifying the median nerve, injecting it, around it, dissecting around it, then I think you would be pretty comfortable pursuing this procedure. The training takes several weeks, I would say, just in terms of getting comfortable with the anatomy and making sure there's no variant anatomy, such as the recurrent motor branch or anything that could be in your way potentially during the procedure. But and then you practice on several cadavers before doing it on actual patients.
That's great. What about future applications for other ultrasound guided nerve surgeries? Any thoughts or anything you're passionate about maybe starting or developing in the future?
Yeah, that's a great question. Nothing is really coming to mind right now, but I'm sure the possibilities are endless now that we're able to continually do things in a more minimally invasive way. I think something maybe I would be potentially interested in thinking about is ablation for Morton's neuromas, which I think maybe has been like published on a little bit, but if we're able to minimize surgery and do things in a more minimally invasive way with ultrasound guidance, I mean, I think that's great.
That's amazing. I love that. Let's transition to your second paper. Can you tell me a little bit more about this paper and how you got involved with the AJR?
Yeah, sure. So I guess I want to start off by emphasizing why there's a need for a women in radiology group. So basically, at this point, women make up more than half of medical students. And there's increasing rates of women in previously male-dominated specialties such as surgery and urology. However, this growth has not really been seen in radiology itself. There's also a lot of evidence that shows delayed career advancement of women in radiology relative to their male peers, and there's fewer women in leadership roles, and this lack of visible female role models can impact recruitment and the advancement of women in radiology. So one of the main benefits of having a women in radiology group is increased academic productivity, more female leaders, camaraderie, support, discussing gender-specific issues, and all of this can help increase recruitment of women. And another thing that's really important for a women in radiology group is sponsorship, which a lot of institutions will have some type of mentorship program, but sponsorship is very specific in that it's active support by an influential person with the goal of advancing your career through high visibility opportunities. And in general, there is an unconscious bias where leaders will promote those similar to themselves. For example, men promoting other men, and women may struggle seeking these opportunities proactively, or may align themselves naturally with less influential mentors. So through the group, it's really important to educate women on the value of sponsorship, how to be a visible protege, and it can be a really helpful avenue to orchestrate sponsorship relationships. So having read a lot about this, as I transitioned from being a resident fellow and attending, my institution has a lot of great female role models, but I wanted more of a structured sponsorship and networking opportunity, and also just like an avenue to talk about with like issues that are specific to women in our field. So basically I joined the AAWR to learn more, and through a subcommittee that I was signed up to be a member of, I met these great women, my co-authors on this paper, who all had so much more experience in creating a women in radiology group. And basically, I just learned from all of their experiences and was able to write this with their guidance.
That's amazing. And what are some highlights, some points for people who want to establish a women in radiology group, or even kind of reinvent or give new light to a group that has been established already?
Yeah, I guess the take home point is that anyone can do this, and you can do it in any sort of capacity. If you don't have the means to make this a formal group that meets every month and has funding and things like that, you can still have an informal group that just meets quarterly to discuss social issues, or just network or socialize, or just discuss more personal issues that are less related to sponsorship and mentorship. But the article is jam-packed with resources, references, ideas for curriculum, things to talk about, how to prepare a budget, and lots of different things to help you basically set this up, which is what I was seeking when I joined the AAWR, was some discrete advice, or basically just a checklist of things to do if I wanted to start a group. So it pretty much summarizes everything that you need to do.
I love this. I remember, when I was a first-year resident at Hopkins, there wasn't a women in radiology group at the time. And I wanted to start one, and I was able to get a small amount of funding and buy-in from the program director. And I actually went around putting like posters on walls, trying to get people to come. And we had, a nice dinner, but it was only a handful of women who attended, and part of the reason was that there just weren't a lot of women. I was the only female in my residency class. The year above me only had one female, so it was challenging at the time. But now I see women in radiology groups at so many institutions, and they really seem to be flourishing with a lot of events, a lot of funding, and a lot of cross collaboration between groups at different institutions, especially in this new virtual world that we live in. Which I love. Can you tell me a little bit more about the Women Radiology Group at your institution and the kinds of things that you do?
Yeah, so the Women in Radiology Group at our institution is still in the early stages, where we are still forming the exact goals of the group. We do have a wide range of women, from those later in their career to those earlier in their career with young children at home. And especially during COVID and a lot of issues relating to childcare, that has certainly created more of a need for, discussion, collaboration, and, expressing difficulties that people are having. And I think one of the biggest things that we are trying to do in the beginning stages, in addition to creating the goals of our group, is to try and not make it so exclusive to women. Mm-hmm. We really do want our male colleagues to be involved in a certain capacity, because they're key to the success of the group, and sponsoring the women and helping advance them as well.
I agree. That was actually going to be a question I had for you. I think in my experience, some of the discussions we've had is that we definitely want to promote he for she and have non-female participants. But sometimes in some settings, it's nice just to have the minority, so that you can discuss personal things that you may not discuss in a larger group or setting. So do you have any insights on that, on he for she, and how to balance the need to be inclusive of everyone, but at the same time provide a safe space for people to really talk about the deeper issues that they're experiencing?
Yeah, I think, like you said, it has to be a mix of different types of sessions. So, periodically there can be sessions that are, just for the women to talk about, any really specific issues unique to women. And then it has to be mixed in with other sessions that incorporate more of the men, and for example, talk about an issue that may be affecting both the men and women, such as salary structure or vacation time, or things that may affect more than just women. And, and it's also important to have men be involved in a sponsorship capacity, educate them on the benefits of them sponsoring women and ways that they can sponsor women. So it's definitely important to have a mix of both types of sessions that include men and women and just the women.
That's great. And you lightly touched about this with the COVID-19 pandemic and the disproportionate effect it's had on women. Can you comment more or just expand on your thoughts about, again, the need for support for women in radiology, especially in the, I don't want to say post-pandemic, or kind of in the intra-pandemic world that we're in right now?
Yeah, I mean, it's challenging. A lot of the, lots of articles have shown that even just beyond medicine, outside of medicine, that the burden of the pandemic has really fallen on women more so than men in terms of childcare and dealing with issues related to that. I think flexibility is really important in order to accommodate things like that. If if someone needs to work from home and we're able to accommodate that, I think, that would be a great adjustment and helpful for women who, need more flexibility in their day. And radiology is such a unique specialty in where we are able to work remotely, easily usually. So I think just more flexibility in the workplace and more understanding would probably be really helpful.
Yeah, that's great. So we have a few minutes left, and I just want to touch upon your experience with writing. It's an amazing accomplishment to have 2 first author publications in AJR, and for some people out there who are interested in research or interested in beginning the writing process, what are your tips for doing research and for getting published in a journal like AJR?
Try and try again. Find yourself a mentor, think about topics that you're interested in, and just put your head down and work. Nothing comes very easily, and everything requires a lot of time and dedication. But if you have the right mentor, they'll really be able to guide you along the right path, give you the right tools that you need to get to, the state of publication. Don't be disappointed if you submit something and it gets rejected. It's very common, and you can learn a lot from the feedback that you get from a journal. And every single time you do it, it gets, what they're looking for. So you know how to really perfect your craft to make it more, acceptable to a journal. But I think probably the first step is finding a great mentor.
Absolutely. Mentorship is so important. Thank you, Sarah. We're out of time, but I really appreciate you joining us and talking about both papers. I know you're on Twitter, so if people have questions, is that the best way to reach out to you, or
Yeah,
how can
that
people
would be
connect
great.
with you?
I'll just pull up this first page. It's just Sarah Kamel, MD, SARAHKAMEL, MD at the bottom of the slide here, or you can email me first and last name at jefferson.edu.
Great. Thank you so much. And I'm looking forward to seeing more papers from you and AJR.
Thanks so much for having me.